Hello, everyone. Good morning, good afternoon, good evening, depending when you are on the world. My name is Nadia Aissaoui. I am a professor in intensive care medicine in Paris University, and I'm currently working in Cochin. It's a great honor to moderate this webinar organized by the European Society of Intensive Care Medicine with Dr. Laura Galarza. She is a doctor in the critical care department in General University Hospital de Catalunya in Spain, and she is also chair-elect of the next committee. We have the chance today to have three international experts on the field, Professor Alexandre Demoule, Professor Luciano Gastinoni, Professor David Termer. They will explain to us how to monitor our critically ill patient on mechanical ventilation. Please, you can ask your question as usually on the TV chain. And now, without further ado, I let my co-chair, Dr. Garzala Laura, to introduce the first speaker. Thank you very much. Have fun.
Thank you very much, Nadia. So our first speaker is Alexandre Demoule. He's a professor of intensive care medicine at the Sorbonne University Medical Center in Paris. He's also the director of the Medical Intensive Care Unit, the Step-Down Unit, and the Greening Center within the Department of Medical Intensive Care at La Pitié-Salpêtrière Hospital in Paris. His main research field is the physiology of patient-ventilator interaction, and he also conducts clinical studies on non-invasive mechanical ventilation in acute respiratory failure and on new modes of mechanical ventilation. So, Alexandre, the floor is all yours.
Thank you very much. Can you hear me? Thank you very much, dear chairwomen, dear colleagues. Thanks very much to the ESICM, to the organization committee for having invited me to give this talk on this MinJari-supported webinar. And during the next 50 minutes, I'm going to try to tell you what are the 7 pressures that I like to monitor in mechanically ventilated patients. These are my disclosures, and let's start now because we have only 2 minutes per pressure. So the first one is the plateau pressure, which is to me one of the most important one. Plateau pressure here on this pressure recording of a ventilator screen of a patient, you can see here an inspiratory pause, and here is on this inspiratory pause, this plateau pressure. And plateau pressure is really important because it reflects the elastic pressure within the lung, and then is associated with the risk of ventilator-induced lung injury. And plateau pressure is definitely one of the most important pressure. I don't look that much at peak pressure because peak pressure reflects the resistive and the elastic pressure. So you cannot make the difference between what is due to resistance and what is due to elastance. And this is the reason why plateau pressure is really important. What we see on this graph on the left is that plateau pressure is directly associated with the mortality of ventilated ICU patients. And you can see that when plateau pressure increases too much, then mortality really increases. This is probably because high plateau pressure is associated with a high prevalence of ventilator-induced lung injury. And we know from many studies that plateau pressure should be kept below 28 centimeters of water, and then we need to adjust PEEP level to reach these targets. The second pressure I currently monitor is driving pressure. Driving pressure is basically the difference between plateau pressure and PEEP. And driving pressure is very interesting because it's directly related to compliance. Basically, compliance is tidal volume divided by driving pressure. Driving pressure is also associated associated with mortality, as you can see on this graph. And you can see that when driving pressure exceeds 14 centimeters of water, then hospital mortality of ARDS patients mechanically ventilated in the ICU increases. So we know that 14 centimeters of water is the right cutoff, but what we don't know is if we need to decrease tidal volume in order to decrease driving pressure when driving pressure is too high. Today, there is no clear evidence, there is no large clinical trial that has shown that we should tailor tidal volume based on driving pressure. Then we have transpulmonary pressure, but I will not expand on transpulmonary pressure because Daniel Talmor will give us a talk on transpulmonary pressure during this webinar. And we have intrinsic PEEP. So, what is intrinsic PEEP? Intrinsic PEEP is generated when there is some a volume of gas that is trapped into the lung at the end of expiration. So we can suspect that there is intrinsic PEEP when we see here on the right, on the flow recording on the screen of the ventilator, we see that the flow is at end expiration is not back to zero. Usually, like on the left, it's back to zero. On the right, it's not back to zero. Then it suggests that there's a volume of air that is still trapped into the lung. And the pressure generated by this volume of air is intrinsic PEEP. And we can measure accurately this intrinsic PEEP during an end expiratory pause that I have shown here. So at end expiration, we interrupt the flow and measure the pressure, and this is intrinsic PEEP. So, problem with intrinsic PEEP. First, intrinsic PEEP is not only, but very common in COPD patients because of the high resistance and low compliance of their lung. Those patients are at high risk of elevated intrinsic PEEP. And intrinsic PEEP has a huge hemodynamic impact when it's high. High intrinsic PEEP decreases venous return, and in turn it decreases cardiac output, and then we have low arterial blood pressure. So when intrinsic PEEP is too high, we need to try to minimize, to reduce intrinsic PEEP, and we can use different strategies. First, reducing tidal volume and also increasing expiratory time by reducing respiratory rate and also increasing inspiratory flow, which is decreased inspiratory time. Then we have arterial blood pressure. Arterial blood pressure is really important. When I was preparing this talk, I just thought talking about all those airway pressures, and finally, no, arterial blood pressure is really important in mechanically ventilated patients. So this is a pressure that I monitor in every patient because of heart-lung interaction. And just two examples, in ARDS patients, when we have low arterial blood pressure, we should, for instance, search for acute cor pulmonale, and maybe in some case reduce PEEP level. And in COPD patient, when we have low arterial blood pressure, we should search for high intrinsic PEEP and then try reducing intrinsic PEEP. And also because in mechanically ventilated patients, because of those heart-lung interaction, we can assess fluid responsiveness with passive leg raising and expiratory pause, etc. So arterial blood pressure monitoring is essential. Then we have a new one, is airway opening pressure. I think it's important to talk about airway opening pressure that was not really commonly monitored 5 years ago, and now there's more and more interest on airway opening pressure. Let me explain you what is this airway opening pressure. Airway opening pressure is completely different from intrinsic PEEP. Intrinsic PEEP is due to flow limitation. And as I showed before, it's measured by an expiratory occlusion maneuver. And last point, inflation occurs from the beginning. Airway closure is totally different. Airway closure is due to the complete interruption of communication between proximal and distal airways. So there's a complete collapse of the airways. And therefore, it's not measured by occlusion maneuver because it's completely collapsed. And inflation starts only when closed airways are reopened. So here we have two pressure volume curves of two patients. On the left, we have a patient with no airway closure. And on the right, we have a patient with airway closure. On the left, we see that as soon as the pressure inside the airway increases, the volume inside the respiratory system increases. On the right, when there is airway closure, we have a totally different pattern. As you can see, at the beginning of inflation, the pressure increases, but the volume does not increase. And then after a certain level of pressure inside the airways, then the volume starts increases. And this pressure above which the volume starts increasing is the airway opening pressure. So this is really essential to search this pressure. So you can search for airway closure and measure airway opening pressure at bedside in your patients. It's quite easy. You just decrease the respiratory rate a lot, 5 per minute. You decrease inflation flow, inspiratory flow, a lot, 5 liters per minute. And then you make a kind of low flow inflation pressure curve. And then you monitor the pressure. And you see here that we have this pattern with kind of two arms. And here we have this airway opening pressure. Why is that important? First, it's quite common in obese patients. 30 to 60% of obese patients have airway closure. And also RDS patients, 25% of patients. It's very important because it creates atelectasis. And then we should set PEEP over the airway opening pressure. So it has to be, PEEP level should be over airway opening pressure. And then also you have to keep in mind that it alters respiratory mechanics measurements and calculation. For instance, if a patient has PEEP of 10 and plateau pressure of 25 and tidal volume of 450, driving pressure is 15 and compliance is 30. But if I tell you that airway opening pressure is 15, then driving pressure is only 10 and compliance is much better than expected. The last pressure I monitor is airway occlusion pressure that we call PO1. So all those plateau pressure, driving pressure, intrinsic PEEP, and airway opening pressure, usually they're monitored in patients who are passively mechanically ventilated with a control mode. Airway occlusion pressure is interesting in patients who trigger their own ventilator. Why? Because this is a measure of the drive. It's a surrogate of the respiratory drive. So it's interesting in patients who are actually triggering their ventilator. So what is occlusion pressure? It's the pressure developed in the occluded airway 100 milliseconds after the beginning of inspiration. So the patient starts increasing, airway are occluded, and after 100 milliseconds, we measure the pressure within the airways. Why 100 milliseconds? Because it takes 150 milliseconds to the brain to realize that airway are occluded. So after 150 milliseconds, the patient starts fighting against those occluded airway. So 100 milliseconds after the beginning of inspiration, the pressure we measure is a direct, is a surrogate of the automatic drive to breathe, what we call the respiratory drive. And a high PO1 means a high respiratory drive, a low PO1 means low respiratory drive. In many ventilators, this measure has been automated. And here are two examples from the paper of Irene Tilias. You see here a patient with a huge PO1 and a patient here with a low PO1. So the range in healthy subjects is 0.5 to 1.5 centimeters of water, but in ICU patients, it seems that it's between 1.3 and 3.5. So what to do? If an ICU patient has a very high PO1, like 4 or 5, it means that the drive is too high and there's a risk of patient self-inflicted lung injury. So you should consider decreasing drive or in some cases increasing assistance, but probably there's a problem here. And maybe the patient is not comfortable and has dyspnea. And if PO1 is very low, like 0.5, probably the drive is too low and there is a risk of diaphragm wasting and subsequent diaphragm weakness. So then we need to decrease the level of assistance to make the diaphragm work again. So in conclusion, and those are my take-home messages, the 7 pressure to monitor. So in ARDS patients under controlled ventilation and also driving pressure, it helps to prevent ventilator-induced lung injury, keep plateau pressure below 28. And also search for airway opening pressure, especially in obese patients, and set the PEEP over the airway opening and closing pressure. And maybe you can use transpulmonary pressure, and Professor Daniel Talmor will tell you more about it. In COPD patients, measure intrinsic PEEP and try to reduce it if it's too high. In patients with assisted mode, assess drive with PO1 and adjust level of assistance. And for every patient, monitor arterial blood pressure, of course, it's really, really important. Thank you very much for your attention, and I'll be happy to take questions.
Thank you very much, Alexander, for your really nice presentation. We will do all the questions at the end after the 3 speakers. So our next speaker probably needs no introduction. Everybody knows Professor Luciano Catinoni. He will be talking today about the 3 recent major advances in the monitoring of ventilator-induced lung injury. Professor Luciano Catinoni is currently a guest professor of anesthesia and intensive care at the Göttingen Hospital in Germany, but before that he was the chief of the Department of Anesthesia and Intensive Care in Monza and in Milan. He has previously served as president of the Italian National Society of Anesthesia and Intensive Care, the European Society of Intensive Care, and the World Federation of Societies of Intensive and Critical Care Medicine. His research is focused on the pathophysiology and treatment of acute respiratory failure, including prone position, and also sepsis and acid-based disorders. He has published more than 300 research articles in reviews and peer-reviewed journals. So thank you, Luciano. The stage is yours.
Thank you. Good morning to everybody. 3 recent major advances. These are my conflict of interest. There should be the coincidence of interest in a Latin language. Anyway. 3 recent major advances. Let me touch 3 points. When to damage a structure, you have to deform up to certain level when you have an elastic structures. We apply one force, and inside the structure, we developed a counter force, which is called stress. And this stress is associated with deformation, which is called usually strain. So in lung physiology, very roughly, we can say that the strain is the deformation of the lung, so the change of lung volume. And the stress is the reactive force we develop to the applied force. And the applied force is transpulmonary pressure. And the stress is equal to the transpulmonary pressure, which a contrary sign is a Newton law. Now, stress and strain are two aspects basically of the same reality. Anytime I apply one stress or one strain, I recover or a strain on the stress. Just to give an idea of the dimension of the problem, these are an old slide from classical and Wood of physiology. Let's see. This is transpulmonary pressure. This the strain at 0 when we have the lung at rest. Now let's see. I double the lung volume. So I have a lung volume of 2 liters. I put 2 liters of tidal volume. I double the lung. The strain is 1. I put another liter. The strain is 2. Now at 1 strain, we have about 12 of transpulmonary pressure. This value is called specific lung elastance, which is this number is 12 plus minus. In the rats is 2. In the pigs is 6. So when you have an experimental lung mechanics, you have to look at what kind of animals you are looking. But this is important to remember that when you increase the tidal volume compared to the resting volume, we enter, when we are about 1.5, and the dangerous regions of the total lung capacity, which is the physical capacity of the lung. If I exceed, I start to break. To break something, I need to put energy in something. As to break a table, or to break a window, or whatever. Now, it's extremely important to monitor, to me, the volumes of the lung. And we have some important volume, which are the FRC, the resting volume. Then usually add the PEEP. PEEP means we increase the volume again. And then if you multiply the FRC, even the FRC of a baby lung, about 2.5, 3, you have the total lung capacity of that particular lung. And this is the regions in which the strain becomes extremely, potentially very dangerous, which of course is a sort of distribution of total lung capacity. Some will be 2.5, some will be 3, some 3.5, but this is the order of magnitude. And now we know that when we have tidal volume per kilo, this is a dogma, no? 6 versus 6. Difference in mortality, this is really 7% of difference in mortality. Before we had 6 versus 10, 7 versus 11, 7 versus 10. No one, the tidal volume per se was worse. The higher tidal volume was worse. Excuse me, the lower tidal volume in these 3 studies was the lower, worse than the higher tidal volume. So tidal volume per kilo makes sense. Look here, why we divide per kilo? To say, okay, I have a big man, big lung. But a big man with RDS, big man, a small baby lung. Look here, this is the ideal body weight, 50, 60, 70, 80. And this we have mild, moderate, severe RDS, total gas volume at 5 centimeters. You see that at 60, you may have extremely low or almost 1.5 liters of gas volume. Here, At 70, we may have very low or we have a very high gas volume. What is important is the ratio between the tidal volume and the gas volume, not with the body weight. The same individual may have a small baby lung or almost an adult lung. So if I have the FRC and I measure the lung volume, the peak volume, I can have an idea of the strain. And I know if my strain is in these regions, I know that the damage in experimental animal is very manifest, very likely in the man also. So instead of kilos, liters of lung volume. Stress, transpulmonary pressure, chest elastance. This is one a difficult concept. But let's see, I have a lung, and to inflate the lung, which is extremely hard, I use 25 centimeters of water to move the lung. Okay. Then when I move the lung are surrounded by the thoracic cage. I have to move the thoracic cage and the diaphragm, so the chest wall. And if the thoracic cage is very soft, I generate a small pressure here, about let's say 5. And this is the chest wall elastance. At the end of my respirator, I read 30. Now, let's see, I have another lung. I use 15 to move the lung. It's softer, but the chest wall is stiffer. I use 15. The elastance total is 30. This is what I read in my airway pressure. But the effects of the lung are completely different. In a normal animal, if I use 24 hours of ventilation like this, I kill the animal. Here, it's completely innocent. Here, the hemodynamic are okay. Here is a disaster. And if you do not know, we just do not know. And this is an example, airway plateau pressure 30 may be associated with a transpulmonary pressure, which is equal to stress of 8 or 24. Each of these lines is one patient. These are patients, RDS, surgical control, and so on. The physics are equal in all physiology. And of course, you may have, during mechanical ventilation, a very low stress, transpulmonary pressure, or very high stress. This is lethal. This is absolutely innocent, depending by the ratio I have between the chest wall and the total elastance. If I do not measure, simply I do not know. I completely ignore the problem. And the stress is further complicated by one thing, the stress risers. The stress rises in the concentration of forces in between structures of different elasticity. As an example, this is the pleura, and you start with the alveoli, subpleural alveoli. This is extreme concentration of stress. And if you notice, many times the video appears as a small bubbles at the CT along the pleural surface. Here, look here. You can see this one. You can see this one. You can see this one. This, the same force is multiplied over there. This is a mid concept. With time, increase in the same space. These are very recruitable, the VD lesions. And then, with time again, we have a disaster. Okay. Now, stress transpulmonary pressure. And even before me, we're speaking about the tidal volume. And a great absence is the frequency. The frequency, if I give a big shot once per minute, okay, I'm not happy, but it's 1 per minute. If I give 30 times per minute, I have 30 shots per minute. So the frequency is extremely important. Now, if you look stress, strain, flow, and etc., respiratory rate, resistances, all this may be summarized in one summary variables. that is not specific. Doesn't tell you where is the problem. Tell you that there is a problem if you overcome a certain level. So if I have pressure, volume, flow, respiratory rate, PEEP, all this pressure, all contributed to the necessity of energy that I have to put in my system. And energy may imply damages. And this is a very simple formula. Don't worry, because here is the frequency. Here is elasticity. Here is the pressure to move the gas, is the PEEP. Okay, we start to simplify everything. What come out? We have 0098 is to convert from liters and centimeter water to joule. Respiratory rate, breath per second, tidal volume in liters, peak pressure minus driving pressure divided 2. So don't ask me, is better the driving pressure or is better the mechanical power? Doesn't make any sense. Driving pressure is part of the mechanical power. The mechanical power gives you the complete picture. And all this data can be displayed on a ventilator easily. And in some places are already done. And when you have something greater than certain usually magic number, here 17, but the problem with mechanical power is how to normalize the mechanical power. No? Because the mechanical power in an elephant or in a rat, to move the lungs and the respiratory system of the elephant, of a rat, is different. So we have probably to normalize or for lung volumes, FRC or compliance, etc., etc. Now, what is I find fascinating about the mechanical power? Let's see. Here are 3 groups of, we are killing a lot of German pigs in the last 3-4 years now to study the VD. And I think this experiment were quite interesting because in a group of animals we use a very high tidal volume, 30 per kilos. Respiratory rate, modest, 10, and PEEP, 5, very low. The mechanical power of this set is 20 joule per minute. Then we have another group in which, tidal volume 10 per kilos. You don't kill a normal lung with 10 per kilos. But the frequency is 35, which is huge sometimes. When the people say, okay, well, increase the frequency, who cares about this? And the PEEP is still quite low, around 78, and I have 20. Now I have very high PEEP, very lower respiratory rate, and PEEP very high, and tidal volume is quite low, not dangerous. So I have 3 packages of the same amount of energy. 48 hours of experiment. I don't go into detail, but at the end, I go to look at the first experiment, lung weight, and wet to dry ratio. A lung weight is one of the systems to approximate the ventilatory-induced lung injury. And you see is per kilo, 20, respiratory rate is same, in joule per minute are the same as this experimental design. The wet to dry ratio is over 6, normally is around 4. And lung weights, we should be around 300, 200, 600, 500, and PEEP. PEEP has the worst systemic effect, the very high PEEP. But also the frequency. I don't give in details the time course, but the end of the story was the same. So that means that there are several things that may produce damage. And until we do not have the complete scenario, it's difficult to understand what's going on. Mechanical power is summary variable that tell you something wrong, as a little bit as the mixed venous saturation or the central venous oxygen saturation, tell you, okay, or cardiac output, or oxygen consumption, or PO2, something wrong. Look at what's happening. Mechanical power tell you exactly the same thing. This is what I think what I prefer to monitor in my patients. Thank you for the attention.
Thank you very much, Luciano. And now we have our third and last speaker. He's Daniel Talmor. He will talk about how and why monitor transpulmonary pressure. Daniel Talmor is the chair of anesthesia and critical care medicine at Beth Israel Deaconess Medical Center in Boston and is a professor at Harvard Medical Center. His field of research is the optimal treatment of mechanical ventilated patients with a particular emphasis on using pulmonary physiology to guide mechanical ventilation. So Daniel, you can go ahead.
Okay, thank you very much for that kind introduction, and thank you to the European Society and to Migrate for sponsoring this presentation. Here are my disclosures. And really, I'd like to talk about transpulmonary pressure today in the context of optimal PEEP. So as everybody on this call, I'm sure is very familiar, large trials of higher versus lower PEEP have been disappointing. So you can see these two large trials, the alveoli trial and the LOVES trial, both used empiric PEEP levels, so PEEP FiO2 tables, and both of these trials were negative. Other trials which tried to use a more physiological approach, the EXPRESS trial and the ARC trial, were either negative or actually showed harm to higher levels of PEEP. So large trials of PEEP have been disappointing, even though many experts would agree that higher levels of PEEP may be beneficial in some patients. So how do we figure out what's going on here? When we take a group of patients and randomize them to either lower PEEP or higher PEEP, we increase the PEEP level, we have a set tidal volume, but rarely do we limit what happens on the plateau pressure side. So some patients, the non-recruitable patients, we increase their level of PEEP and their plateau pressure goes up. Their driving pressure goes up. And in these patients who are non-recruitable, the injury from higher PEEP outweighs the benefit. On the other hand, recruitable patients, when we increase their PEEP, we open the lung, and even though the PEEP level is higher, the driving pressure may actually stay the same or even come down. So these are patients who were recruited using higher PEEP, and the benefit there outweighs the injury. The problem is when I take large unselected populations and randomize them into a PEEP trial, some patients will be recruitable, some won't be. And the end result of the trial is negative because I'm hurting some patients and helping others. So the real opportunity here is to better identify at the bedside which patients may benefit from higher and lower PEEP. And one way to do that is to think in terms of the transpulmonary pressure. So all of us grew up and are used to measuring pressures at the ventilator, the airway pressure. But the airway pressure is not the pressure that actually distends the lung. It's the transpulmonary pressure. That is the pressure that we really should care about. And transpulmonary pressure is the airway pressure minus the pressure of the chest wall pushing down on the lung. And if you can see in this table here, the airway pressure on the x-axis may be very different from the transpulmonary pressure depending on the contribution of the chest wall. So if the pleural pressure is high, the airway pressure will be very different from the actual distending pressure of the lung. Now, how can we measure the pleural pressure and how can we use that to calculate transpulmonary pressure? The only feasible way at the bedside is to use an esophageal balloon. And an esophageal balloon, these are very long, thin balloons placed through the nose or through the mouth into the esophagus and into a retrocardiac position. Here you can see our chief of respiratory therapy placing one at the bedside. And when those esophageal balloons are placed, we can use the measurement or estimate of the pleural pressure to calculate transpulmonary pressure and setting the ventilator. And that's what I'm going to concentrate on today. Now, there's lots of other uses for the pressures measured in the esophagus. We can actually calculate the driving pressure of the lung using transpulmonary pressure. We can optimize our recruitment maneuvers by setting the recruitment pressure based on transpulmonary pressure. And we can calculate work of breathing and detect the synchrony. All of that is out there in the literature. But today we're going to concentrate on setting PEEP. So how would you do that? The esophageal balloon sits here in the esophagus. It measures the pressure in the esophagus, which we use as a surrogate for pleural pressure because the esophagus is in the pleural space. If we then take that pressure, subtract it from the airway pressure, we get transpulmonary pressure. So if the pleural pressure is 14, measured in the esophagus, we need an airway pressure of at least 14 to get a positive transpulmonary pressure. And this can help us set the PEEP at end expiration so that the lung isn't collapsing at end expiration. And I'll just give you a sample from one anesthetized patient. This is a obese patient we had in our operating rooms. And we're measuring the airway pressure, the esophageal pressure, and the volume and flow. And I'm going to concentrate on this area here. We disconnected the patient from the ventilator. We allowed their lung to completely collapse. We're measuring the esophageal pressure here and the volume being delivered to the patient, the volume and flow. So we begin to elevate the airway pressure. We reattach them to the ventilator. And you can see the airway pressure is going up, but there's no volume delivered to the patient. And this is akin to the opening pressure that Dr. Demoule described. It's only when the airway pressure is greater than the esophageal pressure, so the transpulmonary pressure becomes positive, do we begin to see volume being delivered to the lung. And that's this green area. So the weight of the chest wall is pushing down on the lung. And until we overcome that weight, until transpulmonary pressure is positive, we're going to have collapsed lung, which is not being ventilated. And this was also demonstrated in this study by Lorenzo Berra, where they used EIT to look at lung collapse. And they found when the transpulmonary pressure was below zero, so this area here, there was increasing collapse of the lung on EIT. So the theoretical construct was also proven in EIT imaging. We need to maintain a positive transpulmonary pressure to keep the lung open. And we demonstrated that in this small study that was published, really a preliminary study that was published a few years ago, where using a strategy to keep transpulmonary pressure above zero was associated with improved patient outcome in a very small study. Now, the study I would view this more as we didn't hurt people. I wouldn't necessarily say that it helped people, but it definitely, that protocol of keeping transpulmonary pressure above zero seemed not to harm patients. We followed that up with this paper, which was published 2 or 3 years ago, a larger study of 200 patients. And disappointingly, this study showed no benefit to a strategy of keeping transpulmonary pressure at least zero at end expiration. So using transpulmonary pressure to titrate PEEP. But we went back and reanalyzed this data, and I'd like to show you this. This was published about a month ago in the Blue Journal. So first of all, EPVent-2, the second study was not EPVent-1. We used a very different control arm. The question asked in EPVent-2 was, is esophageal pressure guided PEEP better than empirical high levels of PEEP? The original EPVent-1 study had lower levels of PEEP. Now, by using high levels of PEEP, we were using higher levels of PEEP than people actually use in practice. And we made that decision at the time because when we designed EPVENT-2, the recommendations were to use higher levels of PEEP in sick ARDS patients. So these are the levels of PEEP in the control arm of EPVENT-2. These are the levels of PEEP that people actually use according to the LungSafe trial. Now, whether this is good or not, I can't tell you. But we used levels of PEEP in our control arm that were substantially higher than what people are actually using. And because we did that, in the EPVENT-2 trial, we really didn't get separation in the PEEP levels between the two arms. Now, you could say this just validated that using empiric high PEEP may be better or the same as using transpulmonary pressure. But we dug down a little deeper. And what we found is when you looked at what the transpulmonary pressure that patients actually achieved, those who had a transpulmonary pressure at end expiration close to zero did better than those who had a transpulmonary pressure that was either higher or lower. So if you looked at sort of the per protocol outcome, patients with a transpulmonary pressure near zero at end expiration did much better. So this led us to think, we know why if your transpulmonary pressure is low, you're harmed. But what happens to these patients whose transpulmonary pressure is high? And there we re-looked at everything using this approach of heterogeneity of outcome based on patient syndrome. And if you look at that, the lower Apache patients, so the less sick patients, actually did better in the intervention arm. Those patients did better when their PEEP was guided by esophageal pressure. On the other hand, the patients with a higher Apache level did worse when their PEEP was guided by esophageal pressure. So what was happening here? If you look at the attributable risk of death in ARDS, so this is your probability of death, it really consists of two things. Your risk of dying from ARDS-related complications and your risk of dying from your underlying disease, sepsis, baseline morbidity, everything that's going on with you besides your lung. Now, in the low Apache patients, the attributable risk to ARDS is actually high. So an intervention aimed at helping your lung may actually benefit you. On the other hand, in patients with a high Apache, their attributable risk to non-ARDS factors is the major contribution to their mortality. So in these patients with a high Apache score, no matter what you do for their ARDS, you may not be helping them because they're going to die of their sepsis or their pneumonia or their COVID or whatever it is. So by looking at the heterogeneity of effect by the patient's severity of illness, we were able to identify populations that may actually benefit from interventions targeting ARDS. And when you look at the ART trial, so in the ART trial, they used not Apache, they used the SAP score. And you can see that the patients with the higher SAP score benefited from lower levels of PEEP. The patients with the lower SAP score, it was a wash. So maybe here also the higher levels of PEEP in the patients who are sicker may have actually been harming them, and the lower levels of PEEP did better. So how do we tie that together into the algorithm I showed you before? When we have patients who are negative transpulmonary pressure, they are suffering from atelect trauma, okay? So we're allowing their lung to collapse at end expiration. When we take those patients and apply high levels of PEEP, and that drives up their plateau pressure, so their driving pressure is now high, we've gotten close to the transpulmonary pressure at TLC. We've prevented atelect trauma, but we may be over-distending them. On the other hand, if we only limit the end inspiratory stress and we continue to maintain them at a lower level of PEEP, and they have a negative transpulmonary pressure at end expiration, we're going to have atelectasis trauma but prevent overdistension. So I would hypothesize that really what we should be doing is aiming for a physiological FRC, so a transpulmonary pressure that's positive, but then limiting their end inspiratory stress. And I think this is the next direction we will be going, of using the end inspiratory transpulmonary pressure to titrate tidal volume, setting an adequate level of PEEP for a positive end expiratory pressure and a lower level of transpulmonary pressure at end inspiration by limiting tidal volume, with the goal of limiting the driving pressure in the patient. So I think our lesson from EP-Vent 2 was it's not enough to influence the PEEP and to keep the patients recruited. We need to pay attention also to the end inspiratory stress. And the way we can do that is by limiting tidal volume as far as possible. And that will likely be our next trial. And I do agree with the concepts that Luciano has advanced, that respiratory rate also plays a large portion here, and looking at limiting that to avoid the cyclic injury. So why do I monitor transpulmonary pressure? I'm a strong believer that mechanical ventilation should be personalized. I do think that maintaining a transpulmonary pressure close to zero improves outcome. That is in particular in patients who are whose risk of dying is mostly due to their lung injury, and COVID patients are a classic example of that. I think that we can use transpulmonary pressure to help guide tidal volume titration, but I definitely think that we have a lot more to learn on using pulmonary physiology at the bedside. So thank you very much.
Thank you very much, dear colleagues, dear professor, for these great talks. One participant reported that it was beautiful presentations made by the best professor of the world on mechanical ventilation. I will start with some questions for Professor Demoule. Alexandre, one participant was asking, how do you set up PEEP in patient with status asthmaticus?
Thank you very much. Not a simple question. What I would say is that first, don't set a too high PEEP. PEEP level in status asthmaticus patient should not be too high, because the higher the PEEP level, the higher the risk of lung overdistension, and then all the hemodynamics problem that we get in these patients. So personally, you could theoretically set PEEP level to zero, but there's controversial data about this, because some data have shown that maybe a zero PEEP level could generate too much atelectasis in these patients. So what we do basically, we don't do too much complicated things, and we set PEEP like 5 centimeters of water in these patients.
Okay.
Like, don't get into too much trouble.
Thank you very much, Alexandre. Another question, how much inspiratory flow can we keep to reduce intrachectal PEEP? How would you assess the optimal inspiratory flow from graphics?
Tough question. There is no optimal inspiratory flow. I would say that there's critical situations with COPD patient having a too high intrinsic PEEP, and in who we're going to try to do everything to reduce intrinsic PEEP. The first step is to increase inspiratory flow at least up to 60 liters per minute, because sometimes you just look at the ventilator and just, you realize that inspiratory flow is 30, which is way too low in such patients. So for these patients, at least check that it's 60. And then you can increase, at least can increase up to 80 in some patients. But in general, 60, 70, 80. But what is important is to reduce inspiratory time and to infinitely decrease PEEP level.
Thank you, Alexandre. Laura, do you have any other questions from participants?
Yeah, we have a little bit long question, but maybe all of you can give your insight. It's about COVID-19 patients, would give us a lot of thought. So many patients already in a chronic condition of mechanical ventilated already presented a high degree of pulmonary fibrosis with a probable evolution to pulmonary failure. We know that there's a lot of ventilatory-induced lung injury in these patients, but some of them were really, really ill, and we need to increase above the values, the pulmonary pressures that are accepted in the literature. So the question is, to what extent do pulmonary pressure rise already in harmful conditions, in a conditions that we would know that the possibility of life is very low? Is there a risk worth maintaining high pressures knowing the worsening of the disease along with the injuries sustained by the mechanical ventilator?
Wants to start? Professor Gattinoni?
Well, I'm not sure to have got completed.
So I think what he wants to know if the patient is really bad, in a bad condition, and we really need to increase a lot of the pressures. So it's better to increase the pressures and keep the patient alive, knowing that we will cause a lot of harm to him or her.
Well, I will start to pray, or I will start to think to some extracorporeal support. Because very simply, there are a condition in which a safe mechanical ventilation simply does not exist. That's it. So if you accept this concept, you can ask us at which level I will intervene to use the pressure. Remember that anytime we speak of pressures, we speak about the volume. And the volume has some physical constraint, as a pressure has physical constraint. You have to see a more general vision of the problem. And the COVID do have per peculiarity, depending on the stage of the disease. We cannot take what we learn with RDS from bacterial pneumonia and sepsis and translate immediately to the COVID patient. May be a disaster, and I think has been a disaster in many circumstances. Anyway, to answer your question, to me, the usual numbers reported are the usual plateau and so on. I would say that the same plateau of 30 may be for the lung okay, depending by the chest wall compliance. Measuring without the transpulmonary pressure, then you may use in different way. I do not agree completely with my friend Daniel on the use of high peak and so on. But at least we have number on which to discuss. We do not have number, okay, it's a pleasant meeting around a beer, but we have to start to measure this kind of reality. We cannot approach rationally the problem without knowing the number. And if I had to put another stone in the lake about the airway pressure, I cannot think the possibility of a lung which completely close all its airway pressure at the same pressure from the apex, the basis, the dependent and non-dependent. There is something else around. The things are not so simple. But this is against of all the biology I know of. Anyway.
I'll give my 2 cents. I think COVID, we saw a wide spectrum of disease, and it really does speak to the need to individualize to the patient and to understand each patient's physiology. And I'll look forward to meeting my friend Luciano for a beer to discuss that sometime, hopefully soon. But I will say, at least here in Boston, we saw an increase in mortality in the second wave and a lot of patients with pulmonary fibrosis. And in my opinion, this was patients who were left on high flow nasal cannula for a very long time, struggling on high flow and developing pulmonary fibrosis to the point where once they were intubated, they were essentially gone. And we, at that point, you did what you did to save the patient, and you sometimes closed your eyes and turned up the pressures and the volume to try to keep the patient alive. But even when these patients went on ECMO, the result was almost uniformly they died. So I think that question also relates to the overall management of COVID-19 and the roller coaster we went through from early intubation to delaying intubation as long as possible, and now back maybe to earlier intubation.
Thank you, Daniel and Luciano. This was our last question. We don't have any more time, so thank you everyone for being here. Our three professors, Luciano, Daniel, and Alexander, thank you very much for being here today and showing us all your knowledge. Thank you, Nadia, for co-chairing this session. It was really nice having you here. And what's most important, thank you to our audience for being here the whole hour and sending all questions. We couldn't ask you all of them. We are really sorry, but we have kind of time strain. But thank you. Thank you very much for being here today.
Thank you very much.
Thank you all.
Okay, bye-bye.
Bye-bye.